I think what we're seeing is that there is a management strategy that can be applied. It's quite intense, and what we've also identified is that there are lots of these patients out there, and not all of them can follow this route. Is one of the practicalities for our audience. One of the things that I wanted to pick up on was this concept of agency that you mentioned, Chris, and their ability to believe that it's in their control to do something about this. And I just wonder if we could talk a bit about the concept of locus of control. A lot of the patients that I see come and say, I've seen all of these doctors, none of them have fixed me, I just need some more tests. How do we manage this concept of looking for a solution?
Let me show you. We have, sometimes the first step is getting them, actually, can I have control of the slides for a second? There we go. The next step is we have these two handouts, and that's exactly what these are, and those will be available through the RACP site. And one of them is, this is for clinicians, and it talks exactly about how to do that, about how to convey that idea in the room using some specific pieces and dialogue tools, so you can just pull them out of your toolbox when you're with the patient. And this is a handout developed, it's in English, but it's developed by the Danes, and called When the Body Says Stop. And I hand this out like candy when I think there are issues that are comorbidly affecting patients and going through, and for patients and families, in terms of helping them to do that and give that idea. And it directly addresses that idea you're asking about of what's going on with my body, how do I get control over it. If you just Google When the Body Says Stop, it's the first thing that comes up. And there's some other resources that are available on the slide set in terms of looking through, including we're developing a national list for New Zealand of clinicians, psychologists, and psychotherapists who are mind-body inclined, so you have a list of people to assess. And just to throw out there, Urenet Soma, which has done much of the work over the last 2 decades, that's really brought the science to where it is today. But it's that agency issue, those handouts particularly, about how clinicians can use small snippets in the room to create that, and also that handout so patients can take away with them.
That's fantastic, Chris. And I know a lot of the questions related to resources and how we can access resources. And what about, one of the questions was online resources to direct our patients to, where it's not going to be appropriate to refer to an exercise physiologist or a psychologist.
Sorry, can I have the slides back? Again, I'll just show you, because there's there we go. So here, nosymptoms.org is one the neurologists use. There are a few others. I will say about some of these, though, that there are patients, if they're primarily anxious, if you direct them to this the next time you see them, they will have more symptoms, not less, because they will sometimes pick up, oh, I didn't know that was an issue as well. So The Body Says Stop, the main guide, I think is a really useful one, and going from there. But nosymptoms.org is developed by clinicians, by neurologists.
Cool. I'll control the questions. Just to say there's a really good question here, which is, are functional disorders on a continuum wherein the most severe manifestation is factitious illness disorder, Munchausen's?
Yeah. And I didn't talk a lot about this, but you get to this understanding of, it is a continuum. On the left is malingering, where, it's a conscious manifestation. I'm faking neck pain to get a payout, or I don't want to work, or I want to be hospitalized because it's cold outside. Next is factitious disorder, where they're consciously manifesting those symptoms of distress. We have we had a woman who squirted egg whites into her bladder to mimic nephrotic syndrome. Or we have someone who takes exogenous thyroid or exogenous insulin to mimic endocrine disorders, and so on and so on. And that ties into dissociative symptoms, which is part of the reason I mentioned that idea about the elephant and the rider and the psychotic kinds of things. Though factitious disorder is a psychotic disorder. You're doing something to manufacture symptoms in order to be in the care role. Oftentimes because you have such a profound sense of disgust at your core sense of self that you almost have the sense of, the closer you get to me, the more likely you are to reject me. And so, it goes something like this. David, you're such a great doctor. I think you're the best doctor I've ever seen. And those other doctors, like Mark out there, I don't think he understood me, but I really feel safe when I'm with you. I really feel like, you just get me and understand me. So whose hairs are going up on the back of their neck, from that? That's because that's idealization, and what follows is devaluation, of course, and to go through. And that's manifestation of that roller coaster ride that we exhibit, that's suggestive of a factitious experience, where they want to get close, they want to be cared for, but that fear of rejection is driving them away. So they manufacture symptoms to a system that can't reject them, the healthcare system. But it is fundamentally a disorder of psychotic symptomatology, and it goes there. And then you get to somatic symptom disorder, functional disorders, medically unexplained symptoms, whatever you call it, central sensitization, it's all the same thing. And those it's a disorder of the elephant. It's a disorder of the unconscious, the subconscious mind, where they're experiencing, expressing these symptoms in the way that Christy mentioned, and as there's a manifestation of early vulnerabilities, or for whatever reason, but these are real disorders, real dysfunction of real symptoms that are the connection between the brain and the body, but they're not consciously manufacturing them. And then on the furthest side over is anxiety. Now, those patients are the ones who, get 5 mammograms a year and step out of meetings to do breast exams because they're pretty sure they're still worried about having a breast cancer, or they're worried about X. They can be reassured, but only for a moment. You can have a cognitive discussion and say, look, everything looks fine, and they're fine until the next visit. But they don't experience or manifest pain or distress or dysfunction. And that's health anxiety as opposed to somatic symptom disorders. Health anxiety is eminently treatable by psychology and symptomotive exercise. Somatic symptom disorders need psychology, exercise, and sometimes medication. Factitious disorder is a long discussion, but that is about constraint and harm reduction.
Cool. Just time for one more question. This is a doozy. This is the elephant in the room question. There's a lot of anger around these patients. That's what we experience. I've got ME/CFS, and I've seen a number of doctors who are trying to tell me it's all in my mind. But have you read these research papers, which are really clear that there is a pathology here, we just haven't identified it? What are you going to do about that, or shall I just go out now?
Do you want to? I would just say that I'd say you're right. I think it is a very real issue. And I think that there is a pathology, and we are starting to understand that now. We do have an understanding of the mechanism, that it is part of this feedback system. It is part of both how your body is responding and how your brain is responding, but it's very real. And I do what we call the broken record, and I just keep saying it is very real. It is impacting you, and it is something that I want to help you with.
Fantastic. Thank you so much for that. I think that is probably the take-home message for me, that the message that the patient must hear is, this is real, I'm listening to you, I'm hearing you, I hear your frustration with the system. What can we do to help you get through the system? This is a system navigation thing. We've got to stop this cycle that they get into of chasing doctors, of chasing therapists, of chasing investigations. It is iatrogenesis. It is inadvertent harm caused by doctors and other health professionals, but we need to break this cycle. I personally feel a lot more equipped after this session to understand what needs to happen to do that, and I hope you do too. Listen, thank you very much for taking part in this session.